Hello, everybody. I'm Raj,
And I'm Eddie.
and welcome to Blood Cancer Talks. This is a podcast dedicated to hematologic malignancies, where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Today, we have a special episode for you dedicated to a recently published landmark randomized controlled trial in myeloma named MIDAS trial, which tested MRD guided treatment modification in the context of modern quadruplet induction therapy. We are delighted to be joined by an expert, Dr. Meera Mohan, an assistant professor of medicine at the Medical College of Wisconsin. So, Meera, first of all, we would love for you to introduce yourself to our audience. Can you tell a little bit about yourself and what got you interested in myeloma?
Thank you, Raj. It's a pleasure to be here. So my name is Meera. I'm a clinical faculty at Medical College of Wisconsin, and my clinical and research interests are plasma cell and neoplasms. So after my residency, obviously I'm a foreign medical graduate. I had some visa issues. So I ended up in Arkansas doing hospitalist job for the Myeloma Center. And that kind of prompted me to do a fellowship in hematology oncology. But then I did a fellowship in hematology oncology just because I wanted to do myeloma. And at the time when I was a hospitalist there, the Myeloma Center in Arkansas was doing like 600 to 900 transplants a year. And this is really foreign land to me. But then Dr. Barlogi and the team there was really, it was inspiring. And that's really why I chose myeloma.
Yeah, it's really amazing to see that, so many myeloma experts, they have gotten their inspiration from a few centers like, Arkansas, for example, or Mayo Clinic. Thanks for sharing. All right, so now we will go to a case first, and then we'll go over the trial. Just to put the trial in the context, we will discuss the case first. So, a 58-year-old male with revised ISS stage 2 multiple myeloma with hyperdiploidy on FISH started induction therapy with Dara-VRD. He achieves a complete response after 6 cycles of induction, and a bone marrow biopsy done at that time shows MRD negativity by clonoSEQ at 10 power minus 5, but positive at 10 power minus 6. Now, the question is whether to proceed with MEL200 autotransplant versus collecting stem cells and proceeding with non-transplant consolidation with additional cycles of Dara-VRD. This comes up quite often these days in our practice. And the patient is not very keen to get an autotransplant, but will do it if we think that it will really improve his long-term outcomes, survival, and quality of life. So that brings us to the MIDAS trial. And for the audience, I will give a brief background on the design of the trial. So MIDAS is a large phase 3 randomized controlled trial in which patients got 6 cycles of quadruplet induction with isatuximab KRD. So it was isatuximab, carfilzomib, lenalidomide, dexamethasone induction. And then there was an MRD adapted randomization. So after 6 cycles, patients underwent MRD testing by adaptive clonoSEQ, and those who were MRD negative at 10 power minus 5 were randomized to transplant versus no transplant, and those who were MRD positive at 10 power minus 5 were randomized to single transplant versus tandem transplant. So this trial basically asks 2 questions. First is, can we omit transplant in patients who are MRD negative post-induction? And second is, should we escalate to tandem autotransplant in patients who are MRD positive post-induction? And the primary endpoint of the trial was MRD negativity at 10 power minus 6 at the pre-maintenance time point. So, Meera, before we dive into the results of the trial, can you tell us a little bit about the data on the response to ISA-KRD induction therapy? I actually found the responses very impressive, especially when we compare to other frontline trials in this space with Dara-VRD, Dara-KRD. Of course, it's cross-trial comparison, but I really found the results very striking, the post-induction results. Can you give us a brief overview of that?
So at the end of 4 cycles of ISA-KRD on this study, the MRD negative rate to the power of 10 raised to minus 5 was 63%. And most of these patients actually attained deep MRD remission, and the MRD negativity to the power of 10 raised to minus 6 at the same time point was about 47%. So these are really impressive results, to the point that the investigators went back and recalculated the sample size to adjust for the higher than expected MRD negative rate. So initially the sample size was 716 patients. They had to go up to 788 patients. That itself tells us that these were really unexpected and a very impressive result as such. To put these numbers in context, like you said, Raj, we should probably do some cross-trial or indirect comparisons. So we know that the modern-day quadruple induction therapy includes CD38 monoclonal antibodies, DARA, ESA, added to either a VRD backbone or a KRD backbone. So the three main trials that investigated the CD38 monoclonal antibody added to the VRD backbone are the Griffin, Perseus, and the GMMG HD7 study. So obviously these are different studies with different patient population. But then at this, the induction duration of induction regimens across these trials were slightly different. In the Griffin study, patients with newly diagnosed myeloma received 4 3-week cycles. So that was a total of 12 weeks of induction therapy. And at the end of that, MRD negativity to the power of 10 raised to minus 5 was 22%. So obviously lower than what we just saw with the MIDAS study. And deep MRD remission, like to the power of 10 raised to minus 6, was really 1%. So really low in the Griffin study. In the Perseus study, actually, patients received 4 weeks of induction therapy. That's a total of 16 weeks. And they did not report the MRD negative rate at the end of induction therapy, but then we know that following the transplant-based consolidation, the MRD negativity to the power of 10 raised to minus 5 was 34%, and it kind of deepened to 44% at the end of 12 months of 12 months of treatment. And then coming to the GMMG HD7 study, this actually used a prolonged duration of induction. They used 3 6-week cycles. That's a total of 18 weeks of induction. And the MRD negativity rate was about 50%. So kind of intuitively, with increasing duration of induction therapy, the MRD negativity rates as well as the depth goes up across these trials. So coming to the CD38 monoclonal antibody added to the KRD backbone, we actually have 6 clinical trials that investigated this combo, among which 2 of these clinical trials, the GMMG concept as well as the IFM 2018, were exclusively designed for patients with high-risk cytogenetics and high-risk disease. So I'm going to not discuss that because this is really a different patient population. And then the other 4 clinical trial, there's the Master-1 study that used DARA KRD. They used a total of 4 4-week cycles, pretty much what we use in the clinic, 16 weeks of induction. And at the end of the induction therapy, MRD negativity rate was 37% to the power of 10 raised to minus 5. And about 20% of them were actually deeper MRD remission to the power of 10 raised to minus 6. And then we have the ISKIA study that was presented at ASH a few years ago. And then this study used a similar duration of induction regimen, that's 4 4-week cycles. And at the end of induction therapy, the MRD negative rate was pretty comparable, about 45% to the power of 10 raised to minus 5. And then we just saw the MIDAS study, which used a total of 24 weeks of induction, that is the 6 4-week cycles. And the MRD negativity rates, as expected, went up to 63%. And we also saw the results of the ADVANCE study, which was just presented at ASCO of 2025. This study used a little bit of a prolonged duration of induction. They used 8 4-week cycles, adding up to 32 weeks of induction. And the MRD negativity rate at the end of induction was 59%. So what I take away from the high MRD negativity rates that we see in this across these clinical trials is that perhaps we need to do 6 4-week cycles of induction therapy. In my clinical practice, currently I use 4 weeks of quadruple induction regimen. But then given these high MRD negative results, maybe that is what the practice should be. And if we were to do that, it's important to collect the stem cells midway. In MIDAS, they collected at the end of the 3rd cycle, but then I would collect at the end of 3rd or the 4th cycle to make sure that patients have enough stem cells for an operant transplant as such.
Yeah, thanks, Meera, for the great summary. I think that is what my takeaway as well. I mean, typically in my practice, for patients who are transplant eligible, I typically take them to transplant after 4 cycles. Now, looking at all of these data, I'm wondering, should we do 6 cycles? And especially in those patients where we are trying to make a decision based on MRD, I think doing at the end of 4 cycles is a little bit premature because there's a higher likelihood that we will see MRD positivity, compared to doing at 6 cycles, at the end of 6 cycles. But of course, there is no randomized trial between comparing the different durations of induction. But at least based on these studies, looks like 6 cycles is a sweet spot because even with 8 cycles or 32 weeks, the MRD negativity rate is kind of similar.
Yeah, I thought that explanation was really helpful, Meera, because initially looking at those data, I wondered, how much is the carfilzomib making a difference here? But I think the way you explained it, it seems to have a lot more to do with duration. So thanks for clarifying that. So let's move to discuss the top-line results of the MIDAS trial. So first, let's focus on patients who were MRD negative post-induction at 10 to the minus 5. Can you tell us how did the results for the primary endpoint results in the transplant and non-transplant arms go?
So patients who were MRD negative to 10 raised to minus 5 post-induction were randomized to the transplant arm. They got transplant followed by 2 cycles of ESA-KRD, and the other arm, which is the ESA-KRD arm, they got 6 cycles of ESA-KRD. So the post-consolidation, that's a pre-maintenance MRD negativity to the power of 10 raised to minus 6, was 86% with the transplant arm and 84% with the ESA-KRD arm. And this was not statistically significantly different. And we also have to keep in mind that patients who actually went on to be randomized to either of these arms were already in deep MRD negativity to the power of 10 raised to minus 6. In fact, patients who were randomized to the transplant arm were like 73% of these patients were already in MRD negativity to the power of 10 raised to minus 6, and 76% of patients in the ESA-KRD were also MRD negative to the power to 10 raised to minus 6. So this is really patients who are already in a very deep remission. Nevertheless, we did see that there was an increase in the depth of MRD response following consolidation. I mean, these numbers are impressive, but what we like to see is obviously the sustained MRD negativity rates, right? We want to understand, is it going to be sustained at year 1, 2, 3, right? I mean, this is what we like to see. And I'm hoping with longer follow-up, this data will become more clear. We do have some data from an ad hoc analysis, which also included patients where they were treated on the MASTER-1 study that showed that indeed doing a transplant deepens the MRD response. There is a significant reduction in the MRD burden with transplant. So I would, these results are impressive, but transplant will remain as a standard of care in my practice.
So how do these results then play into your discussions with patients at that, either just before or at that time point? Do you mention them, or do they just add to your thinking? How do they shape your thinking at that point in time?
So we already have data that we're not compromising on overall survival by delaying a transplant to first relapse as such, right? So I think given this data, I'm okay with delaying transplant a little bit further, but I can't, I don't think I'd have enough data that would suggest I can entirely eliminate transplant as of now.
And also one thing that I completely agree that we need long-term follow-up, because in the Forte trial also immediately after transplant, there was similar MRD negativity rates, which was the Forte trial for the audience was with KRD or KCD induction. It was not a quadruplet. But then at 1 year or 2 year with sustained MRD, we saw that the transplant arm kind of pulled ahead of the non-transplant arm. So we'll see if that happens here as well or not. But if that happens, that would be, I think, fairly compelling to say that maybe, we don't need transplant for all patients with quadruplet induction. But for now, just with one time point, I think it's still a little bit premature to say that we can completely eliminate transplant in patients who are MRD negative post-induction. So now we will...
Yeah, I just had one more quick follow-up, Meera, on the controller, or it depends how you define which group is the control, and the non-transplant group. So just to clarify, in the non-transplant arm, their MRD to the 10 to the minus 6 deepened from 46 to 84%. That's the group getting more cycles of ESA-KRD. How many extra cycles of ESA-KRD did they get?
They got 4 cycles, extra compared to the transplant. And the transplant arm got 2 additional cycles after transplant as a part of the consolidation regimen. So the ESA-KRD arm, which did not get the transplant, got a total of 12 4-week cycles of ESA-KRD. That's including the induction.
Right. Thanks.
All right, so now let's focus on the patients who were MRD positive post-induction at 10 power minus 5, who were randomized to a single transplant versus tandem transplant. So Meera, can you tell us the primary endpoint results in the single versus tandem transplant arms in these MRD positive patients?
So the patients, as you said, as you just mentioned, the patients are randomized to single transplant versus tandem transplant, and the MRD negativity to the power of 10 raised to minus 6 following a tandem transplant was 32% and 40% following a single transplant. And obviously these numbers were similar and not statistically significantly different. So what really strikes out, what really stands out in my opinion, is the low MRD conversion rates, right? As such, it's about a third of the patients really converted from a positive to a negative status at the end of a consolidative transplant. So persistent MRD disease following CD38-based quadruple induction regimen is really something that needs to be treated differently. And maybe it is in this patient population that we need to further investigate novel therapies such as CAR and bispecific antibody. And bispecific antibodies are being investigated in this setting in the MASTER-2 study.
Yeah, actually, I haven't thought about this before, but now I see that what you're saying is that only about a third of patients who were MRD positive at 10 power minus 5 post quadruplet, they flipped from MRD positive to MRD negativity post transplant, and even with tandem transplant. Yeah, that's very low overall, given that with transplant we would expect more of these patients to flip into MRD negativity. One thing that I wanted to point out here is, for the audience, is that in the tandem transplant group, not all patients received tandem transplant. About 15% of patients did not receive tandem transplant. But of course, the analysis was intention to treat analysis. And here, again, we would like to see long-term follow-up. One thing that I wanted to ask you, Meera, that do you think based on these results, these are kind of the last nail on the coffin of tandem transplant in myeloma, given the
Yeah, I mean,
stamina results and these results?
yeah, obviously we don't do tandem transplants as such in the US. So the study is pretty much confirmatory that tandem transplant may not have a role even in high risk or functional high risk like MRD positive disease post induction, especially with the use of quadruple induction regimens.
Yes. So now let's briefly discuss on a particular subgroup, the T1114 translocation subgroup, which is about 15 to 20% of patients with newly diagnosed multiple myeloma. It was interesting to see that the T1114 positive patients were overrepresented in the group of patients who were MRD positive post-induction. And the difference actually I found was quite dramatic, that just about 24% of patients with T1114 were MRD negative at 10 power minus 6 post-induction, as opposed to 60% of patients without T1114, and almost like 2.5-fold difference. And the gap kind of closed at the pre-maintenance time point, though numerically T1114 positive patients still had a lower MRD negativity rate at 10 power minus 6. So, Meera, do you have any explanation as to why that is? And, especially given your time at Arkansas, can you talk a little bit about the CD1 and CD2 subsets of patients with the T1114 and how that plays into the MRD negativity post-treatment?
So historically, we know that myeloma with the CD2 gene expression profiling signature, that is myeloma that is 1114 translocation, but at the same time, they co-express B-cell markers like the PAX5 and CD20. So we know that we have really long-term follow-up data that is so many publications in this kind of explaining the clinical course or the natural history of myeloma that has a CD2 signature. So typically the CD2 signature tend to have the lowest cumulative incidence of complete remission, and they also have the longest time to complete remission. But then they do have excellent progression-free and overall survival compared to standard risk myeloma. So it's not unusual. If you're going to have clinical trials that's going to be catering to MRD positive disease, we are going to be enriching for patients who have the CD2 or the 1114 translocation myeloma as such. And what really needs to be understood is, does intensification of treatment to fast track to an MRD negative state really improve outcome in these patients, right? We know that even in these patients, when we attain an MRD negative complete remission as such, they are the people who actually convert from a negative to positive state increasingly. And we know that, at least from our experience, that they might not have the same clinical implication as some of the other groups when they convert from a negative to positive state on follow-up, at least.
Yeah, that was really very intriguing. And as you said, I mean, we don't know whether intensification of treatment in these patients is going to improve outcome. It's still, overall in the grand scheme, a small subset, but definitely we saw this year, and it would be interesting to see in other similar trials like Master 2 whether we are seeing a similar phenomenon as well.
Yeah, there was one other thing I wanted to ask, mostly out of curiosity. They used 10 to the minus 5 sensitivity to make for the treatment adaptation decision making, but then they used 10 to the minus 6 for the primary endpoint. How do you think about, do you think that was the right decision? Why do you think they made that decision? How does that play into how you interpret the results?
I would think that, if we were to use 10 raised to minus 5, like logistically, it will be difficult to really have a sample size. Most of the MRD tests that we've done in the clinic, the clonoSEQ, right, they are able to detect MRD disease to the power of 10 raised to minus 6. So that is really, I think it's really like nearly 100% of our samples we're good enough to detect MRD negativity to the power of 10 raised to minus 6. But I would think there might be a statistical reason probably. Yeah.
Yeah, and one more thing is that I don't know, this trial was in the Europe, so I don't know if it did not require FDA approval to open the trial probably, but FDA is quite strict in not letting us making clinical decision in trials at sensitivities more than 10 power minus 5, because for clonoSEQ, the limit of detection is around close to 10 power minus 6. So basically, they want one log greater sensitivity to be able to make clinical decision, because there might be a lot of noise if you go close to like their limit of detection, which is 10 power minus 6. So I don't know if that played a role with the European authorities as well for opening this trial. But the primary endpoint, they kept 10 power minus 6, which I think is appropriate. We have a lot of data now that achieving 10 power minus 6 is prognostically better than achieving 10 power minus 5.
Yeah, no, that's a really important point. Thanks, both Meera and Raj. So next, I want to ask you a bit about toxicity, Meera. There was toxicity data provided by Consolidation Arms, and there was early publication of toxicity with ESA-KRD. Did anything in particular stand out to you in terms of the toxicity?
So before we dive into toxicity, this was really a younger patient population. Right? The median age was 59. That's very different from what we see in a clinical practice. So maybe that might have also factored into the overall lower toxicity rate that we observed in the study. So peripheral neuropathy was seen in 13% of patients, which is really low compared to what we see with the Velcade-based regimen. That's something that I thought was interesting. And then the other adverse effects of interest when we use a carfilzomib-based regimen are the cardiovascular events, and grade 3 and higher cardiovascular events were also low, like 1% across the 4 arms. So overall, I think the regimen was well tolerated. There were 2 grade 5 events. One was attributed to an ischemic stroke, and the other was, we don't know the cause of death, but then these occurred in patients who were already in MRD negative remission, and they were randomized to the ESA-KRD arm and occurred in the first cycle of treatment. So overall, no new signals of toxicity, and overall well tolerated.
Yeah, definitely. I think the age played a big role in it, because we know that with the carfilzomib-based regimens, the risk of grade 3 or higher cardiovascular toxicities, in older adults is very high, is more than 10%. But here it was really low. And that, I would say, it's similar to our clinical experience. Like when I use DARA-KRD for newly diagnosed myeloma in younger patients, is usually very, very well tolerated. I also wanted to give a brief plug for the Master 2 trial, which is a similar trial that's currently accruing in the US. However, there are some key differences in Master 2 trial. So first is it has DARA VRD induction, not ESA KRD, not a carfilzomib based induction. And one of the important points about Master 2 trial is that they do allow patients who have received up to 1 cycle of DARA Cybody or Cybody. So patients with a really high tumor burden or presenting with myeloma cast nephropathy who can't really wait for 4 to 6 weeks of screening, those patients will be represented in the Master 2 trial. And it's similar design, so 6 cycles of DARA VRD and then MRD. And if they're MRD negative at 10 power minus 5, then they will be randomized to transplant versus no transplant. And if they're MRD positive at 10 power minus 5, then everybody gets a transplant. But then they're randomized to either daratumumab Revlimid maintenance versus daratumumab plus teclistamab maintenance. And an important component of the Master 2 trial is that there is potential for stopping treatment, like patients who have 2 consecutive MRD negativity, for example, at the pre-maintenance time point and at 1 year post-maintenance time point, can come off treatment completely, and they will be observed off treatment. So it's currently accruing in the US, and it will be interesting to see the results. I think the transplant versus no transplant results will probably mirror what we are seeing in the MIDAS trial, but I'm really interested about the MRD positive patients who get randomized to Dara Revlimid versus Dara teclistamab, and see if teclistamab is really able to move the needle in those patients who we know are very high risk. So before we end, any other thoughts, Meera? Any ending thoughts? Any about MIDAS trial or the frontline landscape in general now that we have these MRD adapted randomized trials?
I just wanted to add that we already have seen high MRD negativity rates with teclistamab in the, in the upfront setting, right? We've seen the Majestic 4, the EMN 30 study, right? That they had some data at ASH as well. So I'm really looking forward to how the MRD, like patients with MRD positivity do with the teclistamab-based maintenance.
All right. Yeah.
Thanks, Meera.
Thank you.
Thank you.